Another important pathological part of this process is the formation of a blood clot. This very very beautiful and high power micrograph that you see to the left is actually showing you how complex the coronary thrombus is. The strands are strands of fibrin that are trapping the blood cells. You see there red blood cells, but you also see the large white blood cells and the smaller platelets. They become trapped. To the right, you see some thrombus on gross inspection that I was able to fish out of a coronary artery of a patient having an acute myocardial infarction. We put the coin there so you can see what it looks like by size. We always have to talk about thrombin, this incredible multifunctional enzyme that plays a major role in the formation of a blood clot. Thrombin is an enzyme, but it turns out it actually also activates certain cellular functions. Fibrinogen is secreted by our liver, and it is always around, but it's in liquid form. But once it's acted on by thrombin, it then becomes strands of fibrin. So I'm sure you all have at some point seen the very long, laborious thing that you had to memorize, the hemostasis and coagulation cascade. Well, the very last thing that happens in that cascade is that prothrombin is cleaved to thrombin, and then thrombin does its job. Thrombin then cleaves that fibrinogen to the fibrin strands, and it also activates platelets. Thrombin is actually the most potent known activator of platelets. So thrombin, once it's formed, then does two things. These activated platelets express their 2B3A receptors, which link platelet to fibrin strand, to platelet to fibrin strand, and then you have the backbone or the foundation of the blood clot. It turns out that clot begets clot. So once a clot is formed, the natural tendency is for that clot to grow. Activated platelets provide a very necessary activated cell surface membrane for the formation of thrombin, and thrombin in turn is the most potent activator of platelets known to man. So thrombin activates platelets, platelets help to form thrombin, and around you go, and unchecked, thrombus does tend to grow. I like to talk about this vicious cycle. So in order for us to treat our patients effectively who are having an acute myocardial infarction, we have to inhibit both the platelet arm of the thrombosis and the thrombin arm of thrombosis. So it takes both anti-platelet drugs and anti-thrombin drugs. One without the other won't be sufficient in order to break this vicious cycle. Just a note to show you how very incredibly complex platelets are. There are many receptors on the surface of the platelet that can all activate the platelet to express those 2B3A receptors. And once those 2B3A receptors, they really are fibrin receptors, they then are able to platelets link to fibrin, fibrin link to platelets, and then you have the skeleton of your thrombus. As an example of just how important the platelet is in this, we know that aspirin is actually a relatively weak platelet inhibitor. Take a look at all the different receptors on this platelet in the diagram. Thromboxane A2 is the pathway that is inhibited by aspirin. As you can see, that's only one pathway. Platelets can still be activated even if they are on aspirin. So aspirin is a relatively weak platelet inhibitor. However, aspirin by itself has been shown in a trial to reduce mortality in myocardial infarction patients by 23%. So weak though aspirin is, it actually, in a head-to-head trial, was as effective as the thrombolytic drug streptokinase in reducing mortality after a heart attack. We mention this only to show that if this weak platelet inhibitor has such a profound effect on mortality, that lets you know that the platelet truly plays a central role in thrombosis. This is just to show you what happens to the platelets. They undergo this conformational change from a disc or a frisbee to extending these pseudopods. The purpose of that, we think, is to increase the surface area of the platelets for those 2B3A receptors to link up with fibrin strands. To the bottom left of the screen, you're looking at a picture of an angiogram of a right coronary artery that is occluded abruptly just after its origin. And to the right, you see the image of an LAD where maybe you can see the stent or not, but there's a stent there, but that stent is occluded. So there's no contrast getting past that point. In both of these, we know that the platelet really plays a superior role. Just checking my time here. So again, we want to break this vicious cycle. We have to inhibit platelets. We have to inhibit thrombin. We have a number of antiplatelet drugs available. Aspirin, of course, being the universal platelet inhibitor. But we also have P2Y12 inhibitors that inhibit the ADP-induced platelet activation, clopidogrel, prasugrel. There are even others, ticagrelor, cangrelor. But remember, no matter how that platelet gets activated, the final common pathway is that it expresses these 2B3A receptors that allows it to link to fibrin. So inhibiting those 2B3A receptors is a very potent way to inhibit platelets. And we use these often in the treatment of the acute myocardial infarction patient. On the antithrombin side, we've got unfractionated heparin, which is a mainstay in the CCU in treating our heart attack patients. Also low molecular weight heparins, and there are some other direct antithrombins. You can use any ones you want, but the point is, what I want to leave with you is to effectively treat your acute coronary syndrome or your heart attack patient, you must inhibit both arms of the coagulation cascade, the platelet arm and the thrombin arm.